Hi everyone, this is Jennifer. We will get started. Well, actually, you know what? It's exactly 10 o'clock. Good, I'm glad folks can hear. If you have any difficulty hearing me, feel free to jot something in chat, please. But why don't we go ahead and get started? I'm very, very pleased to have you all here today. Happy Wednesday. So welcome, and thank you so much for participating in today's webinar, which is Suicide Prevention, Advancing State Efforts to Save Lives. A few quick housekeeping items. If you wouldn't mind, just please keep your phone on mute unless you're going to be asking a question. And also just use the chat box. We're going to be monitoring it during the webinar, and we'll respond to your questions. And we're pleased to have that discourse. One of the things that I also ask, if you even rotate to the top of the chat box, I've put the link in for the registration for today's meeting. If you haven't had a chance to register for today, go for it. And what would be, but the benefit of that is that when we get done with the presentation today, I'll be emailing everyone then a copy then of the PowerPoint and the materials then that are pertinent then for the discussion. So if you could please do that, that would be wonderful. All right, so why don't we go ahead and get started? Okay, very good. I'm very pleased to introduce you to today's presenters. We have three amazing people that will be speaking. We've got Ms. Danita LeBlanc. She is our Louisiana State Suicide Prevention Coordinator. Ms. Jenna Heights from Texas, our Texas State Suicide Prevention Coordinator, and Ms. Shelby Rowe from Oklahoma State Suicide Prevention Coordinator. And I'll tell you what, these folks have made a marked difference in their states to improve suicide prevention efforts, and they're really outstanding people. Overall, our speakers have really made significant progress with suicide prevention. My name is Jennifer Barron-Prahl, and I'm a social worker, and I'm a project coordinator here at the South-Southwest Mental Health Technology Transfer Center. You're going to be hearing the acronym MHTTC, so that's we'll speak to kind of what my role is here. And I'm very pleased to also introduce Dr. Molly Lopez, who's our director here at the Southwest MHTTC. So we're hosting the event today. And our role as an MHTTC is to share information such as what our presenters are going to be talking about today. And what I'd like to do then to begin our discussion is I want to be sure that you're aware of the resources that are available to you through the MHTTC network. So we'll start by having Molly speak to this and ultimately how the MHTTC can benefit you in your future work as well.
Thank you, Jennifer. We are a fairly young network. We're just beginning our second year, and so I want to make sure that you know a little bit about who we are. So the TTCs are funded by the Substance Abuse and Mental Health Services Administration, and then under our umbrella that you see here are the Addiction Technology Transfer Centers, the Mental Health Technology Transfer Centers, and the Prevention Technology Transfer Centers. We also have a closely related organization, the SMI Advisor, which provides clinical support and technical assistance around serious mental illness. So within each of the TTC networks, the Addiction, the Mental Health, and the Prevention Network, there are 10 regional centers that are spread around the U.S. They're aligned with the Health and Human Services regions. There's also a network coordinating office that helps us ensure that we are coordinating both among the network and then across both the addiction, mental health, and prevention networks. And then there are two specialty centers focused on the American Indian and Alaskan Native population and the Hispanic and Latino populations. So this tells you a little bit about the purpose of the TTCs. So we are around to really develop and strengthen the workforce, the specialized behavioral health care workforce, as well as the primary health care workforce, and even related providers that we know are important to our systems, such as law enforcement, first responders, et cetera. So we work with that workforce to really strengthen their approaches towards mental health prevention, treatment, and then recovery support services as well. We also have the privilege of helping people and organizations really incorporate effective practices into their work, including evidence-based treatments. And we work a lot with kind of supporting and providing technical assistance around those efforts. So we wanted to give you a chance to see the broad region. So we in Region 6 are located in the south-southwest area, but here you'll see across the entire United States the different mental health technology transfer centers. So we know we have a lot of folks that are not within our specific region, which is wonderful. We're super excited about that. And this gives you a chance to see who the mental health TTC is in your region. And we hope that you'll take a chance to reach out to them, look at their websites, and explore what they have to offer to you. Thank you, Jennifer. I'm going to turn it back over to you.
All right, excellent. I do want to echo what Molly just said about having so many diverse people on the call today, and I do think that it's an excellent opportunity to be networking together. So TTCs are one way to be able to do that as well, which is pretty exciting. All right, so as Molly stated, then our region here has taken a particular focus then on suicide prevention in Region 6, and as part of our overall work plan, in tandem then with our other projects, our group then is often, we really wanted to then have this particular webinar to enhance and bring focus and to bring light into the work that's being done with suicide prevention. We've been inspired by the state suicide prevention coordinators, as well as the many other advocates for suicide prevention that we've worked with. September Suicide Prevention Month actually had been a great opportunity to really recharge and reinvigorate our mission to prevent suicide and save lives. We recognize that actually the huge amount of effort that our suicide prevention coordinators are investing to ultimately make change in this area. And we felt that now really is an opportunity, kind of springboarding off of Suicide Prevention Month to then also now take this discussion to the next level to say, all right, how can we really explore kind of our longer term plans to effectuate and sustain change with suicide prevention? And it's pretty neat that the Suicide Prevention Resource Center, or SPARC, which I'm sure folks are aware of, but if not, that's the acronym for the Suicide Prevention Resource Center, SPRC, has offered a roadmap to kind of help with a way forward to improve suicide prevention. That's what we want to talk about. So SPARC conducted an environmental scan and did a needs assessment of ultimately of states' needs to kind of get an idea of where folks were at with their efforts. And from that, they formed an advisory board of experts to kind of share their expertise, talk to focus groups, to ultimately then cultivate input from folks. And it was really noted that states' current infrastructure has some significant limitations. And then from that then, this awesome panel, and we do have a panel, one of our speakers today, Ms. Jenna Heights, was actually one of those people that participated on SPARC's panel, which is excellent. But from that panel, they recommended, they created a set of recommendations then for states. And in 2019 then, what was created, these recommendations were ultimately published then in a document that you'll see kind of outlined here, and we'll have a link for you here. That's the State Suicide Prevention Infrastructure Recommendations. All right. These recommendations ultimately were developed to help state leaders establish a strong foundation then for suicide prevention. And it's a blueprint, and it's a recommended guide to ensure effective, sustainable practices. All right. So if we look at this next picture, then taken from SPARC, again, the state suicide prevention infrastructure, kind of that middle core blue, is defined as a state's concrete practical foundation or framework that supports suicide prevention-related systems, organizations, and efforts. And then this includes kind of the fundamental parts and organization of parts that are necessary for planning, implementation, evaluation, and sustainability. So the recommendations then to develop this framework have been broken into 6 components. So you see those little circles then that kind of then radiate off of that middle blue circle. And each area then represents a core element that's needed to support the implementation of then comprehensive, effective and kind of sustainable suicide prevention efforts. So being able to create suicide-safe communities really requires a shared commitment and vision. So for today's webinar, we'll be hearing from each of our speakers surrounding this state infrastructure model. Specifically, then they're going to delve deeper than within each of those different elements of SPARK's recommendations. They'll share their challenges that they've faced when promoting awareness and implementing policy changes, as well as disseminating training and best practices, as well as in looking at successful strategies then for overcoming those roadblocks. I'm really excited then to introduce you to our first speaker. That's Ms. Danita LeBlanc. And Danita is going to be presenting kind of more of a macro level perspective then from her state efforts. So at this time, I'd like to go ahead and introduce you to Danita. Danita, the
Thanks,
stage
Jennifer.
is yours. Right.
What I did was kind of took those 6 steps and kind of looked at where we were in Louisiana, and then sort of on each of the steps what we still needed to do. And so that's kind of the way I structured this for today. Next slide. So just kind of to get an understanding of the way that things work in this state, we have 10 districts and authorities that basically are responsible for behavioral health care in our state, and they answer to their boards, and their contract is with Department of Health. So we monitor their compliance to contract, statute, and funding sources, but they don't answer to us. And I just wanted y'all to kind of have a picture in your head of Louisiana as a boot in terms of how things are structured in here. Next one. Like every other state, our number of deaths by suicide has been rising for years. So the USA rate's been rising, and Louisiana has as well. Next. Few more specifics. In 2017, we had 720 individuals who died by suicide. Our rate for the last 3 years has been above the national average. Right now, our rate is 15.4. We have learned that 68% of all of our suicide deaths are with firearms. Our youth risk behavior survey has showed us that almost 18% of our youth in high school have seriously considered suicide, and almost 17% have attempted suicide. And our public health office determined that in a 10-year span from 2007 to 2017, 375 of our 10 to 19-year-olds died by suicide. And 56% of those died by using firearms to kill themselves. So just kind of a framework for where we are. The next slide is the authorized slide, which was the first step recommended for state infrastructure. And our legislature last year passed an act that requires OBH to take the lead in the Department of Health to coordinate all the state suicide prevention efforts. And so they authorized us to develop, carry out, and evaluate the plan. They identified that we are to use the Zero Suicide Initiative, and then they also identified all the entities that the Office of Behavioral Health has to work with. Unfortunately, they didn't specify that all those entities had to work with us. And they also wrote it to where when funds become available, OBH is supposed to kind of jump in and take the lead in all this. The other part where we've been authorized is that our Office of Public Health added us in statute to the Child Death Review Panel. That was created in 1992 to look at deaths from 0 to 14, and we were added in the statute about 2017. And our state administration authorized us to use some of the mental health block grant funds towards suicide prevention and crisis intervention services. So we have some authorization, but next slide will say that we still have a lot to do. So yeah, so we really do need to secure some resources for some stable state funding and create a formal suicide prevention advisory board, because right now it's informal. We desperately need to create a new state suicide prevention plaque, as that act requires us to do. And we need to do an annual report on suicide prevention efforts, because none of that's required right now, and I have nowhere to send it at the moment. So the next step in the recommendations was LEAD. And like I said, we're already designated as the lead. What I've done for the last 3 years is spent a lot of time promoting collaboration and coordination amongst the different entities in our state. So Louisiana's funding one full-time suicide prevention coordinator, and that's me. So it's interesting because it's like my salary's funded and that's it. Our administration authorized us to have an additional job appointment to work in suicide prevention. So that should give us at least 2 people to work on suicide prevention in Louisiana. And I've been working closely with the Office of Public Health on an initiative in suicide and self-harm prevention in the southwest corner of the state, so like sort of the heel of the boot, and also in their whole youth violence prevention advisory board coalition. Next. We still have lots to do in terms of leading. We need the data from the Office of Public Health, and we need them to compile it and post it on their website so that we have some data to work with as we focus our suicide prevention efforts and evaluate our results. I think that we need an information network website that's outside of the state system, because our state system's pretty hard to navigate. And I think that over time, we need to move toward developing formal memorandums of understandings and add more content around suicide to prevention to current state contracts. I'm sorry. Next is partner. And right now, what I have is a very informal suicide prevention coalition, but that's probably where I've had the most success in working for the last 2 or 3 years. So one of the ones that we partner with is American Foundation for Suicide Prevention. And the Louisiana chapter is a pretty strong chapter in terms of their fundraising. But one of the things I did partnering with them was to actually join the group as a member. And I also liked their Facebook page, so I knew what was going on. But we have been partnering on training activities around the state. And basically, when there's trainings around, we'll call them and say, do you want to co-sponsor this? And they do, because it ends up helping both them and us to get services around the state. So that I've been real pleased about. And public health, we've been working really closely with, especially since we were added to their child death review panel. There's several other entities that we've been working with around the state in suicide prevention, and we're slowly seeing progress in different areas. So I have one state mental health hospital that's working on Zero Suicide Initiative, and I have one of those districts and authorities who are working on, or which is working on, the Zero Suicide Initiative for all of their parishes, which is what Louisiana calls counties. So with a lot of these folks, it's been a matter of letting them know what the state was doing, letting them know what the data is showing us, offering to partner with them on training, on pushing out information on some of what they were doing through a My State network, which is pretty strong. So those are all kind of where I focused my efforts for the last few years. So the next slide talks a little bit more about the Child Death Review Panel. So yeah, thank you. So these are some of the recommendations we've been working with from the Child Death Review Panel, where we're looking for all the opportunities we have to strengthen and identify opportunities to build capacity. So one of the priority items that we're focused on this year is promoting safe firearm storage across the state, which is real important when 50% of our youth suicides are with firearms and 68% of all of our suicide deaths are with firearms. So Louisiana is a big firearm state, and we're just hoping to get more messaging and more behavior change around just storing them safely than currently exist at the moment. Next one. In the southwest part of the state, so sort of the heel of the boot, we're working on a regional youth suicide prevention project, specifically partnering with an emergency department in the area. So we've worked with them to identify screeners to use in the ER. And at the moment, they're looking at using the Columbia Suicide Severity Rating Scale as a universal screener, and then work with them for care pathways around when individuals need to be admitted and when they can be discharged home. And we're looking at strengthening, when they're discharged home, the post-discharge care management, having the ER work with the youth and families on safety planning, parental education about warning signs and what to do and what the resources are, and also pulling in primary care provider involvement. Next. So what really needs to be done next is we really need a more formal statewide coalition that kind of pulls all the folks I've been working with together in a more organized capacity, and develop some written agreements with partners about who's doing what when, with memorandums of understandings and contracts. Next. So data has been hard to come by for Louisiana. So our Office of Public Health collects all of our death data, and they have been providing analysis upon request, but that hasn't been easy to get to for the last 10 or 15 years because it's not posted anywhere. We have data from the Regional Child Death Review Panel because they look at the death records in those different districts and authorities that they literally look at all the death records of 0 to 14-year-old individuals. OPH, the Public Health Office, also ran a pilot for the National Violent Data Reporting System in 3 of our parishes that we're trying to go statewide. We've had a lot of opposition to expanding that statewide. So OBH is partnering with Public Health to kind of address the objections that have come up in state to expanding that statewide. Still to be done is, next slide. So OPH is in the process of looking at 10 years of data and slicing and dicing it in a bunch of different ways to help us identify the high risk and underserved populations. And so what we'll do after that is share it with those district and authorities, AFSP, everybody else that's working in suicide prevention, because then we'll have some baseline data to work with. I have applied to the crisis text line requesting Louisiana data. I saw Kansas is listed as a state, where you type Kansas to 741-741 so that Kansas can get their data back. And I need to follow back around with them because I haven't heard back from them, but I'm hoping to kind of use that data as well. And all the data from other systems like child welfare, law enforcement, we don't have a way to share those as of yet. That would be really helpful to us in knowing how to target our efforts. What I am hoping is that these 4 pilot projects that the Behavioral Health Office is working with. So in the southwest part of the state, in Acadiana, we're working with a school-based health system on suicide prevention, where they're using the Columbia screener. And we're working with them to kind of see how we can get that replicated in other parts of the state. In that same area with public health, we're working on partnering with that emergency department that I mentioned earlier. One of our districts and authorities is adopting zero suicide, and one of our state hospitals is also adopting the zero suicide initiative. And my hope is that all 4 of those will give us some information and some data that will guide our statewide, the creation of our statewide plan in a more formalized way. So next slide. The next step in the infrastructure recommendation was building. And basically we have a whole lot to be done because we need to design and build the multifaceted, comprehensive lifespan approach across the state. And we need to have a sufficient amount of funding to support that. Cultivate our ability to evaluate data and share it, and get to a point where we can embed our expectations for suicide preventions within all the relevant state-funded contracts with behavioral health care providers, with Medicaid, with our managed care organizations. Next, the final step in the state infrastructure recommendations is to guide. And one of those is identifying and maintaining an updated list of available trainings that meet the relevant state requirements or recommendations. So we have 2 acts that have passed recently for maintaining list of available trainings. And Louisiana as a whole does not have requirements as of yet, like other states do for what needs to be in those trainings. But our start of it is maintaining those lists on, OBH has a list to recommend for assessment, intervention, treatment, and management. And our Board of Elementary and Secondary Education has to maintain a list of gatekeeper suicide prevention programs on the Department of Education's website. And then we've used a good chunk of our mental health block grant funds for trainings to increase regional capacity. Bought materials in 2017, did some training for trainers and assistants, Safe Talk in 2018, and spent 2018 and 2019 doing a lot of mentoring with with those new trainers to increase capacity in the parts of the states where we didn't have trainers in either of those things. So in terms of guide, next to be done is really need to have the ability to plan, provide, evaluate any consultation we do, any capacity building training we do for the state, allocate and identify resources to support it, and then maintain an updated list of the state requirements to meet the acts that require them. So overall, next slide. I'm really optimistic about our future efforts because this is the most political will we have ever had to address suicide prevention in our state. I've been able to identify a lot of organizations working to prevent suicide in Louisiana. And and have got them talking to each other now, especially the ones in the same area, and looking for ways that they can partner and extend the reach of our limited resources. We're getting better data about suicide deaths and have plans in effect to be sharing more of them so that we have baseline data to draw from, and we'll be able to know when what we plan meets some of our goals. I think the collaborating and coordinating that public health and behavioral health have been doing in our state is real crucial, because at one point in our state, public health did all of the suicide prevention, and then it moved over to behavioral health. And I don't think in our state infrastructure that we're going to get very far unless we continue to partner between behavioral health and prevention, because there's really important pieces for both of them that I think are going to be more effective together. And I'm really excited about how much coordination and collaboration is existing in Louisiana at this time. But I'm done. I hope I stayed under time, Jennifer.
Danita, that was outstanding. I really appreciate the information, and it's, again, so timely, and I really, the way you've wrapped up kind of the optimism for the future, I think is also mirrored with just even the number of people that we have on this call right now. There are not only, again, the work that you're doing and what you're seeing in your state, but we see all these other folks that are on the call that are kind of equally motivated for this positive change. So I really appreciate your words and your expertise. So thank you. All right. Okay, we are going to move on now to our next speaker. I'm very pleased to introduce Ms. Jenna Heights. She's our suicide prevention coordinator here in Texas. And Jenna, I'm going to go ahead and give you the floor.
Anyways, hi, Jenna Heights. And I would say I'm having a Monday, but it's Wednesday, so that's not going to be a good excuse. It was really wonderful to hear Danita, so thank you. And thank you to everybody who came on today to learn more about these infrastructure work that we've been doing and helping to advance. It's been really exciting and game-changing for us in Texas, and hopefully for y'all. Hopefully there can be a chance for maybe email exchange or something later to hear what you guys are doing. Yeah, so this is my info. Let's go to the next slide, please. Yeah, so like they said, I'm the suicide prevention coordinator in the state of Texas. And so, yeah, next month I'll have worked here for 9 years in this position. And so this is our Health and Human Services structure. Oh, yeah, good idea. I'll read the chat later. Infrastructure in Texas. And I have a slide later that shows like the beautiful boot we saw from Danita. Our state, I think everybody knows Texas is large, but we have 254 counties that we cover. And so that's quite large. And so I'm situated in the Health and Human Services office, and we have quite a large book of business, as you can imagine, several millions of dollars coming through. And the place where we are is the behavioral health and intellectual disabilities area, overseeing all of those services. Well, I don't, but our commissioner does. And then we're in the Office of Mental Health Coordination, which is a really cool office that was put together by some legislation a few years ago in an attempt to start bringing together and coordinating all the different and various programs that were out there. And really, if you think about it, it is a beginning of some infrastructure building where, we start bringing together ideas and programs and data sets across various and different organizations. So that is been some really nice underpinnings to this work. And I was brought into this office about a year ago, actually, and that's when things started really rocking and rolling for suicide prevention, and maybe just in a new highlighted type of way. The same work is continuing out there with the boots on the ground that's probably been going on for so long that I've been doing this work in the public mental health system space, like our community mental health centers and our state hospitals and things. But this has given us an opportunity to do more of that coordination across all of our partner agencies that I'll start to show. And so to me, it's, the legislation that supports that and this building of this infrastructure really does go in line with what the SPRC recommendations we're talking about. And being part of that, along with probably some of you that are on this line, for the last year and a half, that project and that process, I think, has started just kind of, when you start learning something in your mind and thinking about it, and like maybe like this toolkit, but I think being part of a work group and having to think about it a lot and just kind of mull it over, like, maybe it's the weekend or, maybe I'm at a baseball game with one of my boys, but, and sitting in meetings at work and listening to other things, think now that we're aware of the infrastructure components and these different things, for me, and, if you go through that checklist, like Shelby's going to show and like Danita talked about, we start measuring up kind of where we are with these recommendations for sort of really basic guideline suicide prevention and robust suicide prevention, which I think, of course, we all want, eventually. Then I think because I was a part of that process, I was able to start, really letting a lot of that gel inside of me and drive a lot of the work that I've been able to do in this last year, where I've been able to have this, heightened kind of really perspective, looking across all state systems, and certainly all of the work happening within Health and Human Services, which is quite vast. So all of that to say, I think those are the types of things to try to get a look at. And I think I always felt like suicide prevention was like a redheaded stepchild, which is had nothing to do with Texas or Health and Human Services. I believe it was just the way that mental health and behavioral health has been structured nationally, and the attention and focus that suicide has been given through HRSA and SAMHSA and CDC and like lots of different bodies. And this type of project where they brought in such a multifaceted team to create these. And then the CDC is going to release their report on the state of the states. And they did such a wonderful year-long project and redid all of their marketing and their webpage and, everything that's happened. We're in such a different place now to be able to talk about this. So I'm going to talk about the bottom part of the slide, because all of the me having a team is, I believe, is really a direct correlation to all of this work and being able to really think and be able to communicate and be able to talk. I was able to pull language from the initial underpinnings of what you see in the toolkit and the things that we're talking about today to create these positions and have these conversations and be able to have those types of discussions with partners and people you'll see that go through the slides here. So I do want to just talk about them for a minute because it's so very exciting. So we were able to get mental health block grant dollars because we had a gap between funding years from grants, which is, I think, a really bad cycle that we've gotten into in the U.S., a lot of the states, but obviously not all of the states. And so because administration and other people were able to see that there was no continuous funding for suicide prevention, as you'll see when the CDC report comes out, how many suicide prevention coordinators are actually funded, how many of us actually have programs that are funded and so forth, and where those funding streams come from, we were able to actually get some mental health block grant dollars to put towards a zero suicide effort. And so won't go into that now, but I was able to hire a suicide safe care coordinator that started last January. And so that's just been fantastic because I know that at the very core, our suicide safe care, which is the core of what we're doing here in Texas with our zero suicide and really working on that public mental health system with our community mental health centers, because that's what I was originally tasked with, that I know that that's getting solid attention all the time. And so then I am now free to, again, start pulling back and looking at more of these more strategic and comprehensive efforts. And I believe that's what this takes. And so then we have this newest position that we just hired, and she starts on next week, October 8th. I'm very excited again. And the language for this job description and the need for that I was able to explain to leadership came from directly from the language that was within this toolkit. As we were writing the data and the examination portions of this. And so this person will look over all of our suicide prevention initiatives so we can truly create strategies and have that comprehensive public health approach. So I hired this person and the language that was written was for the public health approach, because we are still in behavioral health services and intellectual disabilities. And so you know, even though we're, doing that work, as we know, suicide prevention has really gotten more towards the public health approach for quite a while now, even though we want it integrated into all of our clinical systems and our agencies that we work with. And so we were able to have that person with that expertise of public health to be able to represent that in all of the work that we do. And so they'll be over, help me with policy, because I do all the bill analysis and implementation for the state. So that's again, another area we're going to have somebody that's their niche. And they'll be over setting all the data, metrics and outcomes. We already have quite a bit around zero suicide, but looking at the whole picture, because we've got a, for example, the NVDRS grant comes our way. There's specific things that need to be measured for that. SAMHSA GLS grant we were just awarded. Again, they're looking for specifics, reportable deliverables, and so forth. So you are able to get all of these different pieces of the pie to try to put together a suicide prevention program. Legislative things come down and they want different things measured and looked at and reported back on. But I wanted to have my own picture based on best practices, research, and outcomes that we could set ourselves and have our own project management looking at the overall bigger picture. And so I hired that person to help me with that. So that we will funnel and stream all those other things into this. So this will be our own larger, bigger picture. And then of course we're going to have our project director will be posting here pretty soon for our youth suicide prevention grant. We're sharing a half-time position with the Texas Education Authority Administration for one of the grants they got from SAMHSA. So there'll be suicide prevention on my team, but they'll also be doing some work on behavioral health in schools. And then very excitingly, well, I don't know if I should say yet, but we have had interviews and made a choice for a candidate for a veterans mental health suicide prevention person. They'll be doing that full time. So next slide. This has been our framework and model for many years. If you've ever been on our toolkit or aware of any of our work here. But again, it's important. I have thought a lot about this, and I believe it's very important to have the core mission of what frames all of our suicide prevention efforts. And so this is still the core mission, but you'll see in a moment how it has grown and expanded over time. So we do want to always be thinking, we work at the state level as the state suicide prevention coordinator. And so what does that mean and how does that look? So that always has to be taken into consideration. And the mission and I guess the vision that I've had for so long is that we would have this suicide safer care state. And then we would have this, the suicide safer care communities, and then the suicide safer care pieces in the very center and heart of things. And that was kind of the concentric circles that would help to wrap around one another and structure one another. But this has grown quite a bit. If you'll move to the next slide. Hopefully this doesn't overwhelm you. I had these like flying in so that it would just be piecemeal, but that doesn't seem to be working. So if you'll just look at that center, and look at whatever you want, but I'm going to talk about this center piece. So we just had those 3 concentric circles in the beginning, and that is still the idea. You know, we want to create that state support around so that the communities and the local suicide prevention structures can have success and exist, and that you know, our policies are creating practices that are making safer systems for suicide care and suicide prevention regionally and locally, as well as for community suicide prevention. And then ultimately at the very center, of course, the person. So we're going from policy to practice to person. And that ultimately it's the person's suicide safer care that is the most important. Excuse me. And I always knew that, and it was always about saving the life, getting the person to care, helping with the suffering through their family, through their care. That was the middle of everything. But I don't know why, I just realized it was important to put that at the middle as the heart. So then you can see the pieces that come around that now for us. And a lot of these are driven by different things, but they have become the pieces that are really a part of Texas suicide prevention now. And so I tried to coordinate like the green pieces to match over here on the one side, the other green pieces that are what inform them and or the pieces that we have responded to those needs with. Obviously at the top you have the state suicide prevention plan. That is going to be the guiding force. And so as we have this infrastructure and this framework, you know, that's always going to be directly tied and intimately woven into the framework, you know, of what we do and that infrastructure. And then we have legislation, and that is also a piece of this. Excuse me. And then over on the right-hand side, which is where my face is right now, so I can't speak to them directly, but we have all these different parts of the puzzle as well that come into play in various different ways. Some of these are voluntold, you know, some of these are mandated legislatively, they're already in statute, they're part of the grants, or they're the best practices that we want to make sure that we are participating in. Excuse me. And so, you know, to me, I was, like I said, this stuff was percolating in my mind as it was, and I was in a meeting with some of my team, and I said, well, look, this is just what I'm talking about. And I just sort of scribbled out and scratched out something that looked sort of like this as an expansion of what we were already doing. And so to me, the reason I need to have some sort of, I'm a visual person, the reason I need to have something like this is because things are thrown at me all the time, and that it's not a judgment, good, bad, whatever, it's just, you know, fact. And so I need a way to be able to speak to the priorities, to be able to speak to the projects we're currently working on, to be able to funnel those into the appropriate place on this this map, if you will, or this infrastructure component, so that it makes sense to people, or to be able to reframe a request to where I can say, you know, this actually now would really work with what we're doing if we could tweak it this way. And sometimes those conversations are with partners or stakeholders or leadership. And that way we're still, it's, you know, sometimes it's a collaboration, a meeting of the minds. Sometimes I have to change, you know, the way I'm thinking a bit and make that look a little different, and that's fine. It just needs to still fit into what we're funded for and you know, structured for, and that people all already understand. You know, the trainings we already have that are funded, the things we've already invested in that our partners already understand. So enough of that, let's move on. I decided to just choose one specific group that we have worked with. Of course, we have a lot of different projects that we're doing right now that I won't get into specifically that aren't on here that we work with, but these are some of the ones that we're working with closely as our priorities right now, like I was explaining. So grade out some of these pieces and decided to focus specifically on our service member, veteran, and their families work that we're doing right now for suicide prevention. And so, of course, in the middle, we still have our person. To the right, we have family and peers. Now, they, of course, we want that to be part of everything. I find that for this piece, the military veteran and service member peer network that we have is just such a huge piece of this puzzle of what we are working on in this space. And so that is highlighted there. And then we are part of some other pieces. And so I'm going to go through all of this here. If you'll go to the next slide. Okay, well, y'all are going to hear these really good from the other. So this is a nice visual I like to think of. And it helps me, again, to frame infrastructure and, okay, well, we can do this or that. This is another way that I think, because I'm not an architect. If you can move into the next slide. I was a dancer first. Oh, if you go back just one second. But some people do music. Some people do, they do build. Can you go back? Yeah. So this is called choreography by design, not accident. And it's just the same concept, but thinking in a different way, as some of us have more of that different kind of creative mind. But it's the same idea. Would we, we can enter into a dance and entering the choreography and creating a dance, but if we don't know the music or we don't know what we're funded for, we don't know the talents of the dancers or even how many dancers or where we will be dancing. I have actually created dances under those circumstances, but then you're retrofitting things in. And so it's what we do in suicide prevention all the time. So to me, I'm never going to move the needle. I'm never going to get us where we need to be without doing it the way that we are trying to do it now. So next. So we have this call to action to help service members, veterans, and their families. I'm sorry for the acronym, but that's a lot to say all the time and fit on slides. So we have this SMVF, just that's who we're talking about. Not going to get into a lot of this stuff, but veterans do represent 20% of the deaths in Texas. Excuse me. So we have these three components. We have 2 cities doing what's called a Mayor's Challenge for Suicide Prevention, working with federal partners and national partners. I'll get into in a minute, and partners across the state. And then we now have a governor's challenge, which is, of course, the larger extension of that at the state level. And so I'm not speaking specifically to like authorize and lead and partner and build and all that, but I do have them on my slides if you look at them. Because to me, they're just sort of integrated into what I'm thinking and doing at this point. But I did try to flesh them out and put them on the slides. Excuse me. And then at the bottom, you'll see Executive Order 13861, where the president last March signed an order for a task force for 3 years to create what's it called? It's the acronym PREVENT, the President's Roadmap to empower veterans to end the national tragedy of suicide. So we're actually participating on that. I believe Virginia and Texas are the only representation of states. And we're working on the line of effort around state infrastructure and community suicide prevention. So very exciting. Okay, next slide. Yeah, so in our Governor's Challenge, we have, I'm leading the infrastructure line of effort. And this is just one of the pieces. You know, you're working with the governor, you have a certain level of authority. So the way that we did this infrastructure goal was to take what's already existing and then how do we enhance it? How do we, expand and support that? So let's go here to the next one. And I think the main point of this isn't to get into the nitty gritty, like, oh, there's a lot of words on this slide. It's to talk about always bringing the work back to the framework, back to the model, and that all of that rests on our Texas Suicide Prevention Plan, the National Strategy for Suicide Prevention, and in this space, it rests on our statutes that we have around veteran suicide and veteran suicide prevention and veterans mental health, and also there's, the 2018 National Strategy to Prevent Veteran Suicide. So if we can go to the next slide. And again, these are things that are just coming out of my mind as I'm starting to think about infrastructures and partnerships and how to visualize it all and look at the interceptions and the connections. So this is, just started trying to think, okay, well, who's all involved in these different layers of these projects around veterans and, this population of our suicide prevention in Texas, and who are our specific players. So you don't need to know what all these acronyms are, and I apologize for them, but this is a way for me and my team to frame out, well, who are these different partners that are at the table? And those little numbers underneath there are our national strategy and state suicide prevention numbers, because again, I just always want those underpinnings to be there. Excuse me. So the next slide. Again, this is just another way to think about it. This is, to me in Texas, I don't believe our infrastructure could exist for suicide prevention without our sort of version of the National Action Alliance, that public-private partnership, which is our Texas Suicide Prevention Council over here, and our state suicide prevention work through our office over here. And I don't believe that everything that comes off of that and that is a part of that could connect to that at the community suicide prevention level, which is statewide, as well as everything that we're doing. So those just need to be very interlocked and key. And so those are all the pieces that are part of that. And if you have questions about that, I'd love to get into that later. But for time's sake, I'll move on. Same thing here. I'm just showing that the Texas Suicide Prevention Council, they are made up of state partners. Many of them are our state partners as far as our mental health and coordination office. And I have just highlighted a couple of key pieces that are part of the Veterans Initiative. Again, I'm not going to be able to get into that, but you can see the families represented and the children pieces through education, workforce development, and our partners through workforce. And again, that very important piece of the peers that are just going out talking to people in the grocery store. Hey, man, you're a vet, I'm a vet, let's talk. Just, real example. And then all our zero suicide work in the public mental health system. And then the next slide. Again, this is the data. We don't need to talk about that specifically, but that we do have 554 veteran suicides in the year we counted this, and 3,339 actual number of deaths. And of course, that's just gone up and up to about 4,000 now in Texas. And that this year, we know that an average of one Texan dies every 2 hours. It's just completely unacceptable. And next. Obviously small print, just the idea of doing a strengths and needs and threats assessment. We did this for our military veteran population, and it was very helpful looking at that. Next. Just bringing you back to this central idea again. Next. I wanted to show what happens to me. I've seen this time and time and time again. We have so much working against us as it is, I believe, for suicide and suicide prevention, just inherently with the apathy, with the stigma, with the don't look, don't tell, and just all of those things, and then the brokenness within our health systems and mental health systems, and relying on volunteers with no funding for the community suicide prevention, and on, that, when we look at a specific thing like veteran suicide prevention, these are just some of the pieces that came from that larger model that I pulled out that you can see are, issues. And to me, they're just floating around like balloons and see this all the time, and they're not attached and brought into the fold. But if they were, we would have that competency for suicide prevention and military culture. Right now, I see veterans suicide prevention coalitions popping up that don't even know there's an actual suicide prevention, effort right down the street, and that they don't want to integrate. So anyways, those are the types of things that can happen. And then to me, the person just gets lost down in the pieces of that down there in the corner. So let's go to the last slide, I think. So to me, again, it's that policy, the practice to person, and at the very heart of the matter, always at the end of the day, if I don't have the state infrastructure to support, my dog is weighing in. Yes, right, girl. That the person and the family and getting the care to them, then, this may be a quote somewhere, but I made it up. I was thinking about it. The heart of the matter is, the heart that matters. That's the end. Thank you.
That was great. Thank you so much for your input. I really liked how you were able to use that infrastructure and use, again, a micro example of working with the veterans. Phenomenal, and how you kind of worked through each of the 6 elements. But then it also, listening to you, you have also this strategic, larger world view, which I really appreciate, and I think we need to be talking about that. So I really appreciated that discussion from local all the way to national kind of initiatives. Really outstanding. So thank you for your presentation. Excellent. All right, we will continue to move forward. I'm very pleased now to welcome Ms. Shelby Rowe. Shelby is our Oklahoma Suicide Prevention Coordinator, and Shelby, you're amazing. You're an amazing person, and we're really looking forward to hearing from you today.
Well, greetings from a coffee shop in Norman, Oklahoma. I was doing a presentation this morning, so out of the office, so bear with me if there's background noise or people calling names. That's because I'm at a coffee shop. So I don't know about the rest of you, but I kind of want to grow up and be Texas. Jenna's system seems amazing, but for a lot of us, can you go to the next slide, please? Not all of us are as big as Texas. Oklahoma, we have some unique advantages and some cool things happening that we're going to talk about. But again, we have some other disadvantages, some geographical differences. Next slide. So here's a quick breakdown of Oklahoma. We've got about, just shy of 4 million Oklahomans, about 70,000 square miles, 77 counties, 512 school districts that operate as their own private kingdoms, and 39 sovereign tribal nations within our boundaries. And in 2018, we had 790 suicides. So our state rate is higher than the national average, but we are coming down. We're 2 years in a row of being under our all-time highest rate was in 2016. 2017, we saw a decline. We went back up a little bit, but we're still under our highest number. So we still feel like things are trending in the right direction for us. Next slide. So I loved this new toolkit and the infrastructure. I was really happy to be one of the people to get a sneak preview of it. And I like checklists and things like that that help make our work objective. Suicide prevention is personal and it's emotional for all of us, and charts and graphs are my safe place. And so being able to take our work and look at it objectively of like, okay, because emotionally, I don't know about you guys, but for me, I think like nothing we do is going to be good enough until we can achieve 0 suicides or until we can dramatically reduce it. And so this infrastructure for me is going to help set objective goals and to help me to see things realistically. So you'll see here's my quick little chart. Clearly my brain does not work like Jenna's, but I took the 6 components and I kind of scored us. I was like, okay, I'm going to look at these green, yellow, and red like a stoplight on where I think we're doing pretty good as a state and where we've got room for improvement. And like at first glance, I will say that I had some of them coded red, but then I went into more details in the guide and I went, oh, you know what? We're doing better on that than I thought we were. So I hope that you guys, as you use the tool, that it's a living tool for you. So it's certainly going to be a living tool for me to just check and do a reality check on a regular basis of, you know, are we doing, because sometimes, you know, good enough or better than the past is still not good for our state. So this tool, I think, will help us to objectively track our efforts. Okay, next slide. So when I looked in the authorized section, I was like, okay, so we have the agency I work for, which I have initials because it's really long, the Oklahoma Department of Mental Health and Substance Abuse Services. We were designated, I want to say in 2003, as the lead organization for suicide prevention. So we have that. We have had for the past, I believe, 4 years, we've had some state funds allocated for suicide prevention. Some of that went for treatment dollars, and some of it went for prevention. This year, our good and bad news is that we were not successful in getting a Garrett Lee Smith grant. Ours expired as of Monday. We do not have federal funding, but our state legislature this past year, they doubled our state allotment. So instead of having a $500,000 annual budget for suicide prevention, we now have $1 million annual budget for suicide prevention in our state, which I'm really excited about how that's going to change our ability to make an impact. We do have a state plan that gets updated every 5 years. Our department works with the State Suicide Prevention Council to make those updates. We've got room for growth. We've got some really complex networks of programs in our state, which we'll get into a little later. But again, many of our tribal nations have federally funded suicide prevention programs. And so keeping in touch with what all of us are doing across the state, there's not a good communication chain so far. We're working on that. Some folks in our office, our tribal liaison for our department of Mental Health and Substance Abuse Services, started a tribal behavioral health association within the state. And we've been going to that as a suicide prevention division, trying to network and touch base with the leaders of all of these other suicide prevention programs going on. And then we have a goal to provide an annual report with our state. We've got our state plan, but then as an agency, we have kind of our work plan for the year. And so we will, by next year, we'll have a good publishable, something we can put of, this is what we did this year. So hopefully by next year at this time, we will have an annual report, at least of what Department of Mental Health did. It may take us another 5 years to have one of everything that happened in the state, but at least we can start somewhere. Okay, next slide. In leadership, again, we're really proud that we do have, with the additional funding, we finally have staff members that are funded through state dollars. In the past, our positions, even though they had some federal funds for suicide prevention, state funds for suicide prevention, those went to trainings and programs and things like that, but it didn't go to staff. Our staff was all funded by grants, which would make things tricky for initiatives because, as we know, with grants come specific requirements of what that person can and can't do. And so our hands were kind of tied with different initiatives. So we are happy now that kind of those limitations are off, and we feel like it's going to help us be more responsive and more agile in serving the needs of our state around suicide. So we've had significant improvement on our capacity, in that just this past year we did, in theory and on paper, we do have an Office of Suicide Prevention. I think that's my office, personal office. I need to change the plaque on the door. But trying to do a better job of breaking down the barriers between our prevention division and our mental health treatment, because we've got a lot of work being done towards zero suicide and SBIRT, And with those being controlled out of different offices in the state, our coordination, we've got a lot of room to improve that, but we're doing a good job. We've set up meetings, and I'm hoping that, that improved capacity is really going to make a difference. And then, our significant improvement, I am not the best at that, but I have an employee who is wonderful at that. We've got a new monthly newsletter where we send out different training events and things. So we're doing a lot better with our statewide leadership of making sure that people know what's happening. Okay, next page. We're continuing to strengthen those relationships. So we've got relationships with our VA. We also we're part of the Mayor's Challenge for Oklahoma City and Tulsa, working on strengthening those connections, because I do love Jenna's map with the little balloons that don't touch each other. We're always coming across new programs that we're like, oh, well, let us connect you with this, or let us connect you with that. We had a different state agency that they're like, oh, well, we're hiring for a statewide suicide prevention director. And we're like, that'd be great. Let's partner with you. Good news. We already have a statewide suicide prevention director, but what would you like to accomplish? Let us try to help you. So good communications. And again, we have, I can't stress enough, like we have 39 tribes within the state. So I think we have a really good working relationship with probably a dozen, like 10 to 12 of our tribes. My department works really well with, which is great to have good relationships with 12 tribes, but there's 39. So we're just a little over 25%, so we still have a lot of work to do. And then some of our new initiatives with mental health and with suicide prevention, Cognito's suite of K-12 programs have really helped to break down some barriers. And then we've been looking for other college initiatives, and this year we're getting ready to launch, which should be available spring semester, the at-risk in college, the suicide prevention simulations through Cognito that we've partnered with our state Board of Higher Regents to launch that through the state colleges and universities. So we're doing some good stuff on leadership. We feel pretty good in that category. Next. When it comes to partnering, so we have our Oklahoma Suicide Prevention Council. This is a council that was established through legislation, and every seat on the council is either appointed, every person is either appointed by the governor or appointed by the head of the House or head of our state Senate. There are some real strengths of that, and as you can imagine, there are some challenges with that, and that we have a lot of people working in our state in suicide prevention that are program directors that trying to get them a seat at that table. We're hoping we can, the legislation comes up to be updated, comes up to be renewed this year. So I'm optimistic that we can make a few changes in the structure to help it better reflect what's happening in suicide prevention. But we do have a standing Suicide Prevention Council that is that good hub for partnerships. When it comes to campaigns, it's really hard for us to spend taxpayer dollars on advertising. So we rely on national campaigns. We email them out. We share them on social media. But we don't really have the capacity at this point. I mean, at some point we may get other funding, but we share what's available nationally, but we don't create our own campaigns. We're always looking for new partnerships. There are always new players in the field that show up that we want to link them in and make sure that everyone's working together in the same direction. Again, the biggest players in our state are the tribal partners. We don't have written agreements, but we do have good communications where I know that they will pick up the phone and call. If we get requests for training in their areas, we usually, the first thing we do is we reach out to our tribal partner. We say, hey, we got this request in your area. Is this something that you guys have the capacity to do? And if they do, we pass it on to them. We certainly don't want to show up in their backyard to do a QPR training when they have the capacity, the ability, and the staff to train their own community. So we do our best to try to connect those, but we certainly don't have any formal written agreements for that. Okay, next page. Here's just a quick little map on the state of Oklahoma. This pulled out section is from that, that up northeast corner of the state, just a visual of all of the different tribal nations. And some of it is the challenges of getting, because we are the State Department of Mental Health, I think there is that we are the authority. But when you look at some of the really sophisticated, robust behavioral health care programs, and so I see on ours of the state responsibility of kind of bridging that, because I think people think immediately to contact us. You're like, oh, like in the area that is the Caddo, Wichita area, just kind of sitting in the middle of the Cheyenne and Arapaho chunk. They have some really good programs in data tracking. And so getting people connected with them, because I know if they have a young person that encounters the police or that goes for treatment, they have staff and programs to go work one-on-one with that individual and their family, and do some life skills training and do some case management that from the state level we can never do. So being able to link them up with their tribal partners is really key. So us knowing what they do help us serve the state a lot better. Okay, next slide. The examine, so we did get increased money, so we're super excited about that. We're really looking to increase the quantity and quality. When we saw a 9% reduction from 2016 to 2017, and we had no idea why. So that didn't make us feel very good, because we couldn't show with our data trail what we did right to be able to maintain that trend. So we're looking for better data sources. One good thing that came out of us working on the Mayor's Challenge and focusing on veterans is we started tracking with all of our community behavioral health centers who is affiliated with the military. So we asked, did you serve active duty, reserve, National Guard? Then asked, did someone in your immediate family serve? And so we can cross-reference our database by county, by facility, by age, to know who we're serving if they're connected with the military. And we've added those questions. We subsidize funding for our 2 NSPL affiliates within the state of Oklahoma. And we've asked them to start, providing us that data of the calls that they receive. For the ones who don't press 1 and get routed, how are they being served within the state so that we can help track that better? And then looking to get better data coming out of we have a child fatality review board. We're trying to get started. We're trying to work and subcontract with an epidemiologist so we can just have a suicide review work group so that we can look at the data from our military affiliated deaths in the state, our youth, and our Native American deaths, because a lot of the areas in our state are very rural. And so when you look at the numbers, without signing confidentiality and non-disclosure agreements, a lot of the data, the program planners can't see for up to 5 years later because there's not stable rates. And so we're hoping that we can be able to set up some work groups to be able to look at this data along with law enforcement and medical examiners and us to be able to examine that data better. And then Oklahoma, we do have a standing group called the American Indian Data Community of Practice that meets quarterly that we participate in. Right now, we're more takers of data. We don't have a lot to share, but it is informative to kind of be at that table. Okay, next. It's the Death Review Committee that I mentioned. We're really hoping to get that started. And we're just looking for better opportunities. Like right now, we have a hard time in our state tracking individuals that show up at an emergency department at risk for suicide. We don't have a good way of tracking that. There were different changes in codes But we're looking for better data on that so that we know. We've got some facilities that are implementing zero suicides in their hospital settings, so we can get some of that data, but we're just still looking for better ways to have more consistent data statewide. Okay, next slide. We now have in our state, we have youth crisis mobile response in all 77 counties. So anyone who's 24 and under, and this is funded through block grant and systems of care, and I think there's some other special funding that the treatment team received. So if someone calls in, it used to be that just if you were in our 2 largest urban areas, you could have crisis response, because again, if you live in a rural or frontier county, your closest community mental health center may be 90 miles away. So to have access for that young person, now true, it may take a little longer for them to come to the house, but it is available 24/7 in all 77 counties. So that is a big jump in our infrastructure. And because we now have our Office of Suicide Prevention, we can share data a lot better to know what's happening with that. We increase our funding, and each one of our goals for our state team, and we ended the grant, my team, I've got 2 staff members, and then we have a data person that's on an evaluator that's on our team part-time. And they're like, oh, yay, we no longer have to track stuff for SAMHSA. And it's like, okay, put away the confetti, because now you have to track stuff for us, because we anticipate at some point we're going to have to fight to keep that money in the state budget or demonstrate why we want more. So each of our goals, like we've got 4 main goals, and each one of our goals, I've got at least 5 objectives for us, and each one of them have data points. So we have a way to measure and prove that we accomplished everything we're spending state dollars to do, because I want to be able to justify keeping that money in the future. Okay, next slide. And we've got our new Office of Suicide Prevention. We are working, again, struggling to work better with our federally funded programs. We were able to partner with our Indian Health Services and be a guest speaker on webinars for all of the methamphetamine suicide prevention initiative grants within the state. But we would like more personal touches. So we're always looking for creative ways for FaceTime with our tribal partners. Next slide. Oh, so that was the end of my slides. We're a work in progress in Oklahoma. There are some things I think we're doing really well, but I know that I can learn from each one of you, and I learned from Danita and Jenna just on this webinar.
Excellent job, Shelby. Thank you so much. Again, outstanding information, again, especially then looking at kind of the unique component that you have with the sovereign nations within your state, and I'm pleased that you're able to share that information with us as a whole. I am cognizant of our time. I want to open up the floor for questions. And while we're doing questions, I'm going to put up a slide that has a link as well as a little QR code scanner. Part of, through the MHTTC, part of what allows us to offer free trainings is that when we get feedback from folks, when you do surveys and you respond to webinars like this, again, it allows us to proliferate and continue to offer more trainings for folks. So while we're answering questions and talking to each other at this point of the presentation, I really encourage you to use a little QR code if you can with your phone. You can just hold it right up to your screen, and we'll post that link here in a moment in the chat bar, but also know that I'm going to send it to you as well too, so know that that's going to be coming your way. But I do want to open up the floor for some questions. Do we have any questions out there for our speakers today? We had one that was online that asked, do folks have state legislation for social media? Social media within your program. So I wanted to put that out there. Or it looks like we have another one that came out as well. But there was a question about state legislation for social media. Any input from Shelby or Jenna or Danita?
Okay, now I should be unmuted. Sorry. So to answer Becky's question and kind of touch base with Grace's question, hi Grace, I'm so glad you were able to join us for this. Welcome back to Oklahoma. We don't have state legislation, but we do have, we now have a new social media person at Department of Mental Health. I know that we all joke, people that are middle-aged always say, hire a millennial. Well, the state did. We hired a millennial, Katie. She's wonderful. She's really good at increasing our game for social media. So we're still working on it, but we certainly don't have legislation. We just, each department kind of manages their own social media. And Grace, for what it would take to establish a messaging campaign, I would say come talk to me. It's one of just getting it approved through our Director of Communications, because yes, with social media, it's just setting up of sharing things. And I am not the best tweeter or social media person. So they ask, and I don't always have good things. So I would love your help of developing, because if we have like, here's 30 tweets this month, or here's 10 posts that we want to make sure get out, we have the infrastructure now at Department of Mental Health to get those put out there. So I would love your help. So thank you.
Thanks, Shelby. And I apologize, I had to just, I was here in the room listening. I know there was another question that was from Grace. Did you continue to talk about that one? I apologize, Shelby, if you had a touch base. Very good. Okay. Awesomeness. Any other questions out there for our speakers?
I have a question from Alaska here.
Great.
We have the highest suicide rate of anywhere per capita in the country. Obviously, our highest is with our indigenous folks on the Arctic Circle, but given the complexity of rural areas, given the complexity of rural intervention and the infrastructure limitations, I'm very curious about this teen mobile infrastructure intervention. Does anyone know how many states currently have a youth crisis mobile suicide intervention structure? That's similar to Oklahoma. Does Texas or Louisiana have one?
Louisiana doesn't have it statewide, but we do have some of our areas that have youth mobile crisis teams. It does tend to be more concentrated in the cities than in our rural areas, and it varies across the state, even when it's there.
So when you look at the demographics of Louisiana, Oklahoma, and Texas, and you look at completed suicides, do you have any comprehensive data on the occurrence of those completed suicides in rural areas versus urban areas with sensitivity to the statistics given the population?
I don't have that yet for Louisiana. Public Health is slicing and dicing it by population density, so urban, rural, suburban. 50 to 80% of Louisiana is rural, so I do want to attend to that way more than I've been able to do with the data I've had.
Well, I appreciate
We have counties that don't have what's considered enough deaths to release, because it would be, it's difficult for them to be then data that can be counted, because it would be easy to figure out who the people were. And it's difficult to then do the data in a way that is consistent with the others. So what we're doing right now is we're actually doing an average and pulling together regional counties to do averages, so we can get an average of our rural areas right now, so that we can have rates for them. We have numbers, of course, but as far as like a rural state rate and things like that, that's one way that we're working on it. But I mean, we do have the numbers, and we do know rate-wise. We've been able to do things like a youth violent death rate, looking at our child fatality review team data, and some different things like that. They've been really useful and helpful. But right now, as far as like statewide data, we have some legislation that is new that's asking us to look at prevalence. So for the sake of prevalence, that's one way that we are going to look at it. I don't know if that's helpful.
Have you been able to extrapolate any correlation between the opioid crisis nationally and completed youth suicide? I know that Southern Ohio has been doing that. Some of the county U.S. coroners across the country are starting to look at the data, and there is some indication actually that may be statistically significant about completed youth suicides and family heroin addiction and opioid methamphetamine.
Yeah, we do have the NVDRS, but it only started last year. But we also have like I said, we have the child fatality review team data. So that is one source where we have a statewide team, and then we have the medical examiners and their child fatality review teams where they do a report every 2 years. I think HRSA requires that. And they have the form for that. So that information is ready. But we also have the opioid dollars that we got, and they have an evaluator and an evaluation team. And then we have our Center for Health Statistics at the Department of State Health Services, and they also have a team looking at that, the Center for Health Statistics, with a separate grant. So we are looking at it in different ways. And then, as I mentioned, when we did that state violent death youth rate, we were able to drill down to zip code and look at the highest violent death rate in zip code. And then the child fatality review teams convened around that, and we did look at causes and conditions. And in one of the rural ones, we did find that it was related to drugs and dealing and drug use.
Thank you,
Thank
Jenna. This is Jennifer. We're going to have to honor your time. It is 11:30. Outstanding presentations today. Thank you all, Danita, Shelby, Jenna, for your excellent work. Thank you all for the participants. We had a load of folks on the call. Grateful to have you. But I ask again, please take a moment to complete the survey. If you haven't had a chance to register, please do so. The link is at the very top of the chat. And if you've registered, then that'll allow me to get you all the PowerPoints and any information that we spoke about today. So I want to thank everyone for being a part of this presentation. Outstanding. Thank you.